without further ado, I'm going to just sort of introduce people here, and then we'll begin with a presentation from Brenda Butcher, and then we'll move into some questions on that, and then into a panel discussion. I want to just say on behalf of United Way of Lancaster County, we're grateful for your interest in community health and wellness. We're grateful that you're taking this time, whether you're a panelist, you're a participant, or you're out there catching the recording later. Thank you for taking the time to look into this series that we're putting together of really important conversations around health, public health, in the grandest understanding of that. Because as we said at our first forum, public health is not just public health care. Public health is the health and wellness of a community. And that veers into everything historically, from healthcare to seatbelts, to lead testing, to issues of incarceration and public safety. And so we want to help the community understand that these conversations are broad and extremely important, and there's not a single member of Lancaster community who is not impacted by the public health decisions or lack of coordinated decisions that happen. So thank you for your interest and for talking about these issues with your friends. The most powerful thing that will happen today is not what the 7 of us say. It's what all of you who observe, who watch, who listen to this, whether it's live or recorded, it's what you do, what you carry from this, the conversations that you engender, the sharing of this video, the interactions between yourself and your friends and family. That is where this conversation gains its power. And so we're grateful to be a part of that. And so I want to introduce our panelists here. John Carlson is lead pastor at Forest Hills Mennonite Church. Forest Hills Mennonite Church is the church I grew up at. And so I'm grateful for John carrying the torch there, that community. John also is involved with Mennonite Church USA, which is the largest denomination of Mennonites. He is on their executive committee. He also has been nominated to be the incoming moderator. So hopefully all goes well here for you, John, in that process. And thank you. The next person I want to introduce is Luz Colon. Luz is the executive director of the Governor's Advisory Commission on Latino Affairs. She also is on the COVID-19 Vaccine Joint Task Force for Racial Equity. It's a subcommittee of the Joint Task Force. Dr. Cherise Hamlin is founder and president of Patients Are Waiting. She's an OBGYN. She's co-chair of Diversity and Inclusion Advisory Council for Penn Medicine, Lancaster General Health. She's an officer of diversity and inclusion there. She's also Lancaster General Family and Community Medicine Residency Program. Dr. Dan German, quick clap there. The doctor was newly added, I believe, last weekend. So Dr. Dan German just graduated with his doctorate of ministry from Lancaster Theological Seminary here in Lancaster. He's the executive director for the Office of Advocacy and Reform for the Office of Governor Tom Wolf. He chairs the COVID-19 Vaccine Joint Task Force on Racial Equity, that subcommittee. I believe he also serves on the General Task Force as well, or reports to it, I should say. And so Dan has been instrumental in some interesting conversations and work that's been happening at the state level. That office is new, so Dan is also sort of establishing that new office, and we thank him for his service to the community through that. We have Susan Baldridge here. She will be our moderator. She is a moderator extraordinaire from our last conversation, we know this. She's also the executive director for the Partnership for Public Health. That leaves me, President and CEO of United Way of Lancaster County. I also, for the context of this conversation, I am chair of the board of Meals on Wheels. I'm vice chair for the Partnership for Public Health, and I'm a member of Landis Quality Living Board, and I'm a member of UPMC Livet's board. And I also serve on the COVID-19 Vaccine Joint Task Force for Racial Equity subcommittee. So without any further ado, I'm going to invite Brenda to go ahead, and we'll begin with this presentation on where we're at with vaccines. So thank you everybody for being here.
All right, good morning everyone. I'm going to share my screen. Does that look okay for everybody?
You're good, thank you.
Great, thank you very much. Okay, so I'm going to just hopefully set up the discussion that we're going to have by giving you a little bit of data about where we are with vaccinations in Lancaster County. I'm going to start with a few slides just to put in context how important vaccination is and access to the vaccine. So As we all remember, this slide shows new cases in Lancaster County. The most recent week of data we have would be last week. We had 575 new cases. That is the lowest number we've had in quite some time. So we had a very large spike in new cases beginning in the late fall through the holiday season. Cases started to decline in January, February, and then we had a little bit of another spike in April. But since then, for the past few weeks, we've seen declining case numbers again. And if you'll remember, the vaccines were first authorized in mid-December, and that's when healthcare workers started getting their vaccines. When we look at COVID-19 deaths, they tend to follow by about 2 to 4 weeks behind cases. So the shape of the curve looks similar. We had a spike in deaths following the spike in cases around the holidays, and that has come down since with another small increase in April, and again now has started to come down again. So we're still seeing deaths every week. The most recent week we had 7 total deaths, but that number does follow the cases that we have. And then the other thing that's important about when we think about vaccine access is the new and emerging variants that we have of the virus. So this chart shows the percentage of cases that are for each strain of the virus by state. B117 is the strain that infectious disease experts were predicting would become the dominant strain in the United States over time, and it has. So at this point, 51.8% of the cases in Pennsylvania are that B117 strain. These are estimates that the CDC does from the testing that they do on what kind of viruses are circulating in the community. Oh, and one thing that's important about this is that this is a variant of concern because it is believed to spread more easily, but still does respond to the vaccine and the other prevention measures that we use. Okay, so that's the background. Now I'm going to show where we are overall with vaccination in Lancaster County, and then we'll start looking at some of the disparities. So overall in Lancaster County, as of last week, we had 234,000 people who had received at least 1 dose of the vaccine. So in that little table, you can see that that's 180,000 people who are completely vaccinated and a little over 53,000 who have 1 dose so far. They're partially covered. The State Department of Health publishes the percentage of the population age 15 and older that's covered. So that's roughly the percentage of people who are eligible for the vaccine. I expect that they'll change that calculation now that 12 years old and older can get the Pfizer vaccine. But if we're just looking at the population 15 and older, 52.8% of the population has gotten at least 1 dose of the vaccine in Lancaster County. This chart shows per capita, so per 100,000 people, how many people have been vaccinated. So you can compare rates across counties. And this is all the counties in Pennsylvania. The dark blue bars, which is the bottom of the chart, are the rates of people fully vaccinated per 100,000, and then the gray bars are the people who are partially covered. So Lancaster is the bar that's in orange, and we rank 20th right now in per capita vaccination rates among all those counties in Pennsylvania. And one thing that's important about this, when I started tracking this data in early April, Lancaster County was 44th. So once the community vaccination center opened up at Park City and we really started rolling out with other community clinics, we really moved up among the counties and how many people we were vaccinating. Okay, and now we'll look a little bit closer at different groups. And all of these slides that I'm going to show are the percentage of the population in each group that is fully vaccinated. So this chart shows by age group. The orange bars and the percentage values are the percentage of that age group that's fully vaccinated in Lancaster County. And then I have the gray bars on there just to show you what it was last week, so you can see how each group is progressing. So of course, age 65 and older, those are the age groups that have been eligible for the longest time. And those age groups were, nearing or just past 70% vaccinated. And then the rates are lower for younger age groups. Another thing that's important to remember is that chronic diseases do increase with age. So that's another reason that some of the younger age groups, but who are closer to 65, might have been more eligible because people with chronic conditions were eligible earlier. And the other thing to notice about this is that all of the age groups are still increasing. So, it might seem concerning that the younger age groups, we only have 20 or 30% vaccinated. They're still all increasing. Many of those folks just became eligible a few weeks ago. When we look at gender, this looks at Lancaster County compared to the state of Pennsylvania, just so you can see that. And we have a higher percentage of the female population vaccinated compared to the males in both Lancaster County and in the state of Pennsylvania. And then this chart shows overall vaccination rates compared to the vaccination rates by ethnicity, Hispanic versus not Hispanic, and then racial groups. So I'm sorry, I've reversed these for you, but Lancaster is still the orange and Pennsylvania is still the dark blue. So a couple things to notice here. The overall rate of fully vaccinated people is 40% in Lancaster County. And then the reason that sometimes these numbers might look strange is there are a good proportion of people that we have, their race or ethnicity is unknown. So that's kind of the gap. But when we look at Hispanic versus not Hispanic, 37% of the not Hispanic population is vaccinated versus 22% of the Hispanic population. So there's clearly a disparity there. And then among the racial groups, you can also see that the white racial group has a higher vaccination rate than the other racial groups that we have on this chart. One other thing to notice is that across the board, Lancaster has higher percentage vaccinated than the state of Pennsylvania. And again, that's because our per capita rate is pretty good. And we also have less of a disparity. So compared to what is happening in the state of Pennsylvania, we have done a little bit better on making sure that all of these groups are getting vaccinated. So still a disparity, but something good is happening in Lancaster County. And so hopefully we'll have some more conversation about that. And here's just one example that I wanted to leave you with about how these strategies can work. So there are many organizations that are working on community outreach. The folks on this panel will talk about that. This is just the example of the community mobile clinics that Lancaster General Health has done. So we have done 6 clinics. So we vaccinated a little over 1,200 people in these community clinics that are done in partnership with organizations in locations that the community is familiar with. And that is compared to the Community Vaccination Center, the big one at Park City, where they've done over 100,000 vaccines. So you can see this is the percentage of people that have been served in each racial and ethnicity group. And so overall, the community vaccination centers breakdown roughly reflects what the breakdown of the population in Lancaster County is, with a little bit more overrepresentation of the white non-Hispanic populations and a little bit less representation from the other groups. When you compare that to the community mobile clinics, which again have been specifically done with attention to those barriers that might exist and trying to overcome those, we have better representation for the groups that we have focused on so far. So Black and African American community, that makes up about a third of the people that have been served in those clinics. And then about a third of the people who have been served are Hispanic. And those are two specific groups where we have worked with community partners that have really made that possible. So hopefully that introduces the rest of the conversation we're going to have about some of the other strategies that have been successful and can continue to address that disparity that we're still seeing in the data. And I will stop there.
And I realized I forgot to introduce Brenda because she wasn't on my list of panelists. Brenda is not just a random interloper. She works for LGPen and does amazing work within their community wellness. What exactly is your title, Brenda?
My title is Health Promotion Specialist. I'm responsible for community health needs assessment at Lancaster General.
Thank you.
Thank you, Brenda. That was really informative. And there's a couple things I took from that. One is that we're getting to do a better job, but we still have a long way to go. And I also think that we should be higher on the list of vaccinations per capita than 20, since we're the 5th or 6th largest county. But hopefully we're going in the right direction. I think I'd like to start out with Luz Colon and ask her a question about how do you think, Luz, that the COVID-19 crisis has brought into focus for many people unaware or ignorant to the fact that there's a health disparity out there among different demographic groups. How do you think that COVID has brought that to light?
Well, I think that number one, I've kind of mentioned this on different circles of conversation where it has brought a lot of fear to our Latino communities. And we want to work with our stakeholders in order to find out exactly why are they feeling fear, why are they feeling anxieties, and why some of our populations in different areas in the county is, or in the state, I would say, are hesitant in receiving the vaccination. So I want to dive into a number of things because we know that there is a major disparity or health crisis, I would say, within the Latino populations on a, I would say, national level. I mean, argue that point where, I think that other states are probably kind of dealing the same thing. And although
I ask you for a minute to clarify something?
Sure.
When you say you're seeing fear in the Latino population, what exactly are they fearful? What do you see the biggest issue that they're fearful around? Getting the vaccination, getting COVID?
I think it could be to a number of things. But the first thing is just data collecting, getting their information, checking the box, putting their information in somewhere in a system where they don't know exactly who may get it at the end. So that for us, and where we have spoke to a different to stakeholders and just trying to figure out exactly, why. And we think obviously it had to do a lot with the some of the older administration, prior administration, with a lot of executive orders that had came out, one of which is called public charge. They have a lot of fear in just checking the box. So what we need to do collectively is try to just share facts about why is it safe, why the information that they give us will be private. Those are really key. And just to answer the question, I think that those are very two key points. Is one is the fear of putting their information on a piece of paper, and two is perhaps the distrust with the federal government, with so many things that happen with census, with just as an example, with public charge, where we are working towards trying to give information and educate the community so that we can combat those fears. So I hope that kind of sums it up in a sense.
I think I think when you hit on trust issues, I think that's really key. Dr. Hamblin, what are you seeing in your patients as far as their fear of COVID versus fear of vaccination? I think that's one thing that we're all dealing with.
Yes, there's fear everywhere. I think we've all been living in it and through it, but this pandemic, there's an intersection of a lot of things. And so the fear that Luz mentioned, where why would I trust a system that is actively harming me today, not historically? Why would I trust that I'm going to be protected or that I'm going to be served? And so to make that plain, for organizations or for events that we did with patients are waiting early on this winter when vaccine was available for phase 1A, we went into churches, into community centers, and we didn't collect demographic information because we knew the demographics. And part of one of the things that is a difficulty with how the pandemic is playing out is that when we have the most chance of collecting information, we measure what matters, right? And so if we are wanting to place resources accurately, then we would measure or collect the demographic information when we're testing for COVID. And then our vaccine sites would match the highest rates of COVID or the communities most affected. We can look at socioeconomic indicators and look at that on a map. That is not where in city after city, there is not an overlay of highest COVID rates with vaccine sites. And there's many reasons
Exactly.
why.
And there's not a correlation also, which leaves many of us unaware of why there's such a disparity. There's a higher death rate amongst people of color and a lower vaccination rate. And
Right.
so
And part of
I
that,
think we're getting to that issue right now
yes,
with
early
this
on, there was a lot of, and I was asked to write articles about hesitancy in communities of color. And I was hesitant to even write those articles because part of the narrative that is shared is basically, you're afraid and it's your fault that you're dying. And that is absolutely incorrect. I am afraid because I can show up somewhere. I'm a doctor. And so I'm invited into rooms and spaces where on a day that I'm not wearing my white coat, I'm not invited to, where I'm overlooked or I'm passed right by. And so, again, if we just use simple logic and put resources where they are needed, then we will have effects. And when we do that over and over, we build trust. And when we build trust, it is easier to save lives.
But what you're getting at, I think, tell me if I'm wrong, is that there hasn't been this trust. And I think Ms. Cologne said the same thing. There's historic distrust for good
I'm
reason.
talking about present day. If I apply,
there's historic distrust, but you're saying continuing to this day. And I think the COVID crisis has just sort of brought that into a better focus.
yes, but we're still myopic. Our corrective lenses are not working because we could see from COVID rates and infection where things were happening, disproportionate effects. Then as we roll out vaccination, even honestly, even using age, if we use age as the collector or as the qualifier, we are advantaging white population. Just longevity is associated with, because all of the social determinants of health are there. And so if we have a 5 years younger life expectancy for African Americans in this country, then guess what? Fewer are going to be in that range. And if we're just talking about hesitancy instead of addressing it, then we're going to continue to see the disparate outcomes that we see. And what plays out on a national level will play out in Lancaster County, will play out in Lancaster City.
I
can real quickly add
Kevin,
to this.
I was going to call on you, Kevin. Like, what are you seeing No, I know you were anxious to get in there, but what are you seeing and hearing about these issues and how it's this disparity that basically we haven't paid attention to that is just bleeding right into this pandemic?
Right. One of the things that's happened at the same time as the pandemic is an awakening for many people that the Voting Rights Act in the 1960s didn't solve all of our race problems, right? So they're playing catch up, and at the same time they're trying to show themselves as being the greatest arbiter of knowledge here. And what we're hearing is, and it drives me nuts, anytime I hear that Black populations are hesitant because of Tuskegee, I get very frustrated. Not because Tuskegee may not play some part in that, but to what Dr. Hamlin's saying, that was not the last time that Black people were treated poorly in the confines of the medical systems. Serena Williams, world famous tennis player, greatest tennis player of all time, has a daughter, and the doctor isn't listening to her talking about her history of blood clots. She has to get out of the bed and grab her own chart and walk down the hallway to demand that she gets attention. Serena Williams isn't getting adequate medical care. That's not in the 1950s, 30s, that's in the 2010s, the later 2010s. And so when we talk about Tuskegee, in some ways it does actually against of what it's actually trying to do. It's saying, oh, there's this historic reason for distrust, but there's no reason for distrust. No, there is reason for distrust today. Just 3 years ago in California, they were doing forced hysterectomies for migrant women in detention centers without consent.
Kevin, let's bring it to Lancaster County, because the civil unrest, the protests of last year, the census, the previous administration, all of these things are, there's a confluence of issues.
Mm-hmm.
Right here in Lancaster County, Ricardo Munoz, this is now, this is today. That is where health, policing, all of these things coming together, it's all related. And so when we look at how do we build trust in medicine, how do we engender confidence in communities that are hesitant, part of it is representation matters. Netflix seems to get it. I can turn on, find a playlist of things, every show that I put on for my kids. There is so much more representation now on television, specifically on Netflix. Some channels are better than others, but what about in medicine? In medicine, and I can't, in my group of 7 OBGYNs, 2 are African-American. Part of the work of Patients Are Waiting is increasing diversity in medicine. Why? Because it saves lives. That when we see racial disparities in healthcare, in medicine, they are addressed partially by having diversity within the healthcare workforce, not because a Black doctor is more likely to, or is better at treating Black patients off of, some kind of historical, or there's some shared understanding, sure. However, the disparity in the physician population, the clinician population, is a result of racism. There's 5% of physicians in the United States that are Black.
You're right.
That's been since the 1960s.
And so you're talking partly about education. So I grew up in Lancaster County. I went kindergarten through graduating at Conestoga Valley, and I didn't have a single non-white teacher. 13 years, not a single non-white teacher. We know that students are 39% less likely to drop out if they have one teacher who looks like them in their entire public school education. They are 29% more likely to apply to college by having one teacher who is just physically there. And so if we have that lack of, all the way at the beginning, seeing people in positions of authority that you can rely on to have some level of understanding of what it might be like to be you, I think you're absolutely right. That just trickles up. So now you've got less people in the pool at college, less people in the pool to go to. I mean, the work that you're doing is so important. And I've had conversations with you and your group to know that you're saying, okay, how do we go earlier than college? That conversation has to start so early. So, I just wanted to say that, Susan, that when we talk about this messaging, we've got to not talk about what happened 60, 70 years ago and pretend like there are not. I mean, look at all the examples that Dr. Hamlin just gave. that are not happening still today actively in these moments. Because why am I going to trust someone who doesn't know that bad things have happened to Black people or Latin people in the last 50 years? Like, that's just, it's not a reliable, trusted source. And so the other thing that I would say is I think that we really have to be intentional about highlighting then the trusted sources for those communities. We talk a lot about getting a celebrity to do something, but what about the grandma on the block that everybody relies on after school to watch them until their kids get home? That woman is trusted in the community.
And I think we're going to talk a little bit more about that, but I'm going to ask Dan to jump in here and tell us what we can do, because let's just face it, this is a white problem. Whites created this system and they're controlling the system. And so we need to be part of the solution, a big part of the solution. And I think awareness is just a little tiny piece of that, but we need action. So if you don't mind jumping in here, and I'd like you to weigh in on some of the things you think we could do.
So first I'll make the problem worse. So as a half Puerto Rican, half white guy, let me throw out that it's also poverty. So we have redlining, and the redlining maps line up exactly with where we see life expectancy differences. But all of those things are also connected deeply to poverty. They're connected deeply to trauma. We know that children with 6 or more adverse childhood experiences have 20 years less life expectancy. And we also know from the Philadelphia study that there's more than those 10 original ACEs. So when the Philadelphia ACEs study looked at an urban population that was much more diverse, what they found was that the traumas were at a higher rate. And they included things like experiencing racism and discrimination. They included things like being in congregate care, so foster care and the juvenile justice system, both of which we know disproportionately affect people of color. So it's this combination of all of these things, and it forces people into the situation where they're under-resourced. They're not able to access the same health care, and as was already pointed out, they're treated differently. And so I would say, since this is a public health conversation, for me, the first thing that comes to mind is the social ecological model in public health. And in that model, we don't just say it's an individual's fault and we need that individual to stop acting this way. That's true. That's part of it. And we don't just say it's policy and we need our policy, our legislators and our policymakers to make different decisions. That's true, but it's not the only thing. We also need social capital, peer support. We need to influence the people around people to make better decisions about how they treat other people, about whether or not they get the vaccine, about whether or not they follow public health guidance. We need organizations to change the way they function. And so, for instance, as has already been pointed out, you can't, county after county after county, you can't have your only vaccination site far away from all the people who most desperately need the vaccine. It doesn't matter that you give free bus passes, because I've got to take 3 hours out of my day to take that bus. And I don't have 3 hours, I'm going to get fired. I'm not a salaried middle-class person who can just take the day to go, half a day to go get a vaccine. That's not going to happen. I might not even be a first shift worker. And so we're not thinking about the actual logistics, because we tend to design things for people just like us. And when the people just like us, when the people in power and everybody else just like them doesn't need these additional equitable adjustments, then people get left out of life-saving care. And then we also have to change our community and how we think about things in the community. One of the things I pointed out when I was the chair of the Mayor's Commission to Combat Poverty back in 2016 is actually more true now. Most poverty in Lancaster County is outside of the city and is rural, white poverty. And so there's this discrimination that, first of all, poverty is a Black and brown problem, but also there's a disconnect around how you reach all the people who don't have the resources to get to where help is. So it is an issue of racial equity, and it's also an issue of social justice and classism that we have to work on together to get to a place where we recognize that we're leaving a lot of people out of just life, liberty, and the pursuit of happiness, right? Like you can't have the pursuit of happiness and liberty if you're not even getting life. If we're just we know now, I mean, we know that from the ACEs study, we know from trauma research, we know years and years of documented racism. Like we know now, and this pandemic has pointed out the inequities that we have in our systems. And so now it's a moral imperative. Human beings, just like us, made the decisions that got us where we are. We're human beings too. We can make different decisions, but we have to make them at all 5 of those levels in order to really make change.
And I will mention, because I was on a year-long panel during COVID with the emergency management to get sites up for vaccinations. And originally there was a site in rural parts of the county. There was a site at the school district of Lancaster, and then the general site at Park City. And you'll have to ask the county commissioners how they honed that down to just Park City. I just don't feel that people in all areas have a great access to walking in and getting a vaccination. Thank goodness for Union Community. They do vaccinations in the city, but there's a lot of people that just don't have easy access. And if we don't start thinking about all the people, we're never going to improve the public health of Lancaster County. And so I want to come back to the economic issue and also touch on mental health disparities. But I first want to bring in John and have you weigh in on this issue. And then I also want you to speak for all white Christians, if that's not
Yes,
unfair.
I can
It might be
definitely
a little
do
unfair, but I'd still like to ask
explain
you a question
everything
about that.
about white people and where we have missed the boat here.
Okay.
Yeah, so I think I'm here really to try to sort of help make that intelligible. One of the things we saw early on in this conversation was a lot of media hand-wringing about hesitancy among Black and Brown communities and Tuskegee, and that's sort of exactly what Kevin and Dr. Hamblin were talking about, this erasure of current health disparities and saying, oh, well, there's just historical mistrust issues, but we'll fix it. And then the African-American communities, Latino communities, Asian American, Pacific Islander communities, they'll get vaccinated. But then what we actually started to see is the greatest hesitancy, where it really is about hesitancy and not lack of access, was from white evangelicals. So I pastor a Mennonite church. Some Mennonites would accept this label of evangelical, some would not. It's obviously a very loaded, fraught term. We're sort of evangelical adjacent. That's how I like to think of ourselves. And what I've heard,
what's the excuse? What's the excuse for people who are privileged, white, educated? I'll try not to put anything in air quotes, but why? What's the reasoning? Is it all
what is
political?
the reasoning? Yeah, so we're in our own congregation, we're seeing really high levels of acceptance of the vaccine. I'm really thankful for that. But more broadly, the conversations I'm having, I hear 3 primary objections or concerns. One, there are concerns about ethics. Right, so the evangelical movement has in many ways defined itself around opposition to abortion. And so there's concern and misinformation that these vaccines actually contain aborted fetal tissue. It's not true, but it's a perception that's out there. So there's an ethical concern. Am I being unethical or unfaithful by accepting this vaccine? Then there's a safety concern. We don't know what the long-term effects of this vaccine will be. It's new technology. It hasn't necessarily been comprehensible to the average layperson. And so there are real concerns about safety. What will be the long-term effects of this? People hear phrases like messenger RNA. They don't really know what that means. Is this changing my DNA? You hear concerns about fertility. So there's safety concerns. And then there are trust issues. Just as we're hearing described from Dr. Hamblin, from Kevin, there are trust issues. They're different issues, but there still are trust issues. Trust about the role of government in private life. And real concern there, and then also trust about big pharma. And we've seen, this is an ancient history, this is recent history. We've seen the ways that pharmaceutical companies have behaved unethically in the pursuit of profit in the opioid crisis. And so these are the 3 concerns that I'm seeing most prevalently. They're ethical concerns, safety concerns, and trust issues with the government and trust issues with the pharmaceutical industry. And my visceral reaction is just frustration. Like, this pandemic has upended my life for the past year. Like, I haven't had fun in a year. And so finally, we have an opportunity. We can end this together, and people aren't willing to do it. And so I get frustrated. And so for me, what's been really important is to try to discipline myself, to draw on my own faith tradition and realize that what people need when they're feeling these concerns is not sanctimony, not anger, but they need compassion. Now, sure, there are people who are taking advantage of this in the pursuit of power or profit and are trying to maximize, amplify people's fears. I'm not sure those folks need a whole lot of compassion, but by and large, the average person, we need to acknowledge that they feel afraid, and that they feel bad about being afraid because they've been trying to trumpet and champion the fact that they're living with faith over fear for the past year. And so to be honest about their fears is really hard for them. And so I try to find within myself, as difficult as it is, some compassion for folks who are feeling this sort of hesitancy to help move them along this journey. And I think a lot of that does need to come from their trusted health providers.
I wanted
That,
to
that
jump
is,
in if that's okay. I'm really sad that Jackie Concepcion couldn't be here because, some of the work that we're talking about it has squarely sat with Union Community Care. When Brenda gave the numbers, we talked about the vaccine site having served 105,000 people, 84% of whom were white. The LGH Community Health pop-up clinics serving 1,200 people, 52% of whom were white. I know from Patients Are Waiting, our work was, we did 3 pop-up events, one in conjunction with LGH Community Health, serving 845 people, 45% of whom were Black when we last counted. And it was interesting, but I want to mention 2 things. Union Community Care, as I said, we know that they're in the community, right? They're, and now merging Lancaster Health Center with Welsh Mountain, they're in the city and they're in the rural. They are caring for the medically indigent, and they were at the front of testing before contracts came through for LGH to be the major testing provider for people without a medical home.
they were also at the front of contact tracing.
At the front of contact tracing. So when I think about what we can do, part of it is, if we see that the organizations are doing good work, give them the money that is needed, because there's no way that this work gets done without paying for it. People's time is valuable. We can look at this very simply in, economic and health inequality or inequity. They mirror each other. So if we have all of the resources, of course, we're going to have better outcomes or better capacity to do things. And so I can think of early on, I remember when Patients Are Waiting, we applied for a Lanco Cares grant through United Way and Lancaster Community Foundation. And I was so appreciative and thankful, like, oh my goodness, we were able to work with local church, Faith Tabernacle, and do a food campaign, launch our doulas initiative, all of these things. When I looked at the grants that had been given, Lancaster Health Center at that time got maybe $7,000 for headsets. I mean, I'm sure it must have been what they asked for. But we are so much better than this. It can't be possible that all they needed was $7,000. Why not give people what they need? Give organizations what they need. You see them doing work, thank you, here you go. We can look at what the federal dollars are and all of that. And I know that may not be how we're set up, but I think that if anything that the last year has told us, it is that we need to pivot. I will say Union has had some significant challenges, as any federally qualified health center has had, where even some of their staff has left their jobs at Union to go and work at the community vaccination site because the pay is much higher. And we're basically asking people to volunteer to do their jobs, and then asking people to kind of chase the money around for a couple dollars differential. And these are the same people who are kind of disproportionately affected. But then when we have people in the city, neighborhood champions and those things, we ask them to volunteer. Give your internet to help this person. And people do lots out of the goodness of their heart. I'm really thankful and appreciative that Union actually asked Patients Are Waiting to help get vaccine out in the city. That's going beyond their patients. And literally next weekend, we will start 10 weeks every weekend vaccinating people from 8 to 5 at various sites throughout the city to try and advance vaccine equity in Lancaster, because the need is so great, the work is so much, and we can share it. There's 60,000 people in the city of Lancaster. We can do this. I'm going to put the link in the chat. And even, if you're not vaccinated yet and you want to be, there's definitely opportunity. Also, I want to just shout out SAL, South Asian Association of Lancaster. They vaccinated 15,000 people. On any given Saturday at the Wyndham on Route 30, there were English, Hindu, Gujarati, Spanish being spoken with over 70 volunteers every single Saturday, many of whom I work with. And shots in arms, they got it done. And, there's a lot that can be learned from these different experiences. And I just want to shout out the work of South Asian Association of Lancaster and NCS Pharmacy, Dr. Chetan Patel, who really just said something has to be done. He tried to do it in the city, and that, things did not work out in the city. And he just basically, the Asian community really came out in full force to do their part in Lancaster, and more than their part. And it was a real pleasure to work with them.
Yeah, Dr. Hammond, we were getting from SAIL, South Asian Association Lancaster, we were getting messages. I was getting messages. I've got 20 minutes, Kevin, and I've got 6 shots. And I was Facebooking people, and literally that's the level of granularity that they were hitting on. And I also want to highlight on the Union Community Care, much of the work that they have done and did was uncompensated because the way that the structures of financial support have gone. And as you pointed out, their financial structure means that their employees are often paid less than same employee, same quality within another health system. And then they're being given less resources when they already have less to begin. So I fully agree. And I want to just say, because you talked about Lancaster Cares, philanthropy needs to change. Philanthropy, so yeah, we gave them what they asked for, but philanthropy has to be willing to say, and oh, by the way, you can ask for more. And sometimes we did that. But like, hey, you asked for this because you are in an environment that you are so afraid that you're not going to get anything that you ask for less. That's the way nonprofit mentalities have often become. And when Patients Are Waiting came to us, one of the things that I went was initially based on the guidance of how our processes at United Way and Community Foundation were set up. It wasn't an organization with 2 years existing track record. So you disqualified. And I went and I said, nope. I said, if this doesn't fit under the guidelines of that program that we have, then I will have to find money elsewhere, but we're not going to not fund this. And since then, both County Foundation and United Way have said, oh, no. We can't hold ourselves away from supporting important things because someone hasn't existed for 2 years. Again, this is a way that we wait towards historical and we support things that have existed, which is maintenance of power. And so philanthropy has to be willing to say, you know what, the biggest organization with the best marketing budget may not be where we need to put our dollars. And we may need to be willing to take some risk in betting on new and innovative ideas and solutions, instead of always funding the bang on average that has worked for 30 years, hasn't solved any problems, but we know that they'll do exactly what they say. We won't have any new solutions, but
so Kevin, I want everyone on the panel to do what you just did. I want everyone on the panel to charge us with a mission that we need to accomplish now and in the future to continue to accomplish so that some of these disparities can change in the right direction. What should we be doing? And I mean nuts and bolts, boots on the ground. What can we do to change this? And for the people who are listening to this and the people who will listen to the recording, what should we be doing? Please charge us with this. I'm going to start with John because
well, I have by far the least expertise in the healthcare field of anyone on this panel. So, from my vantage point, what the church is good at historically is helping people understand our deepest values and try to live them out. I say we're good at that. Maybe it doesn't feel like there's a lot of evidence that we're good at that these past few years or even past few decades, past few centuries. But at our best, that's what we do. We help people understand our deepest values that contribute to human flourishing and live them out. And how that gets lived out in this particular context of public health, I'll defer to the experts like Dr. Hamblin.
Yeah, but I think I'm leaving you're getting off the hook there. It's a little general. And I want you to say, what would you say to your fellow white Christians about how they could change this situation that is been made clear in this hour. This disparity has been made clear. What should white Christians say to each other?
Sure. If we're talking specifically about vaccine hesitancy, I would appeal to my fellow white Christians, please get vaccinated, talk openly about it, address the concerns, and celebrate the progress that we can make against this pandemic together. As we think about broader issues of racial disparity, we have hundreds of years of injustice that we need to confront together. Some of it starts with being honest about the ways that we have benefited from unjust systems, even if we did not build those systems. And then some of it continues from that acknowledgement to asking the question of what do we do now? And that touches every aspect of life, where we live, where we send our kids to school, what we do with our money, where we go to work, who we hire. All of those questions are questions we need to be asking ourselves.
Thank you. I thought that was insightful. Dan, do you want to go next? Because we only have like 6 minutes left, so I want to get everybody a chance to get their voice in here.
I'll go super fast. So the first thing I would say, the good news for what Dr. Hamlin and Kevin were talking about is the money that came from the last Relief Act through the Biden administration, from the CDC to our State Department of Health. Every category for its use is based around racial and economic equity and vulnerable populations. So the money in category after category, it has to be used to reach out to FQHCs, to local grassroots nonprofits, community-based organizations. So the dollars are categorized for exactly the things we're talking about. It's just government, so it's not fast. So it was approved a few months ago, and we're churning through all the hoops that you have to jump through to get the money out. I would say, since I've just finished my doctorate, as Kevin said, at the seminary, my focus was on being more relational with people. We have to stop throwing stuff at people and acting like that's okay. Pastor I knew when I worked briefly in Florida, gave the analogy that it's like finding a family in a hole and walking past it and throwing some food and blankets down so they're more comfortable in the hole, and then walking away. They're still down there, and so we've got to actually get down with people, meet them where they are. First of all, respectfully offer help, because it's not always wanted. So asking people if they even want our help, and then climbing down in the hole with them and helping them long term, not just with transactions, but with deep relationships. You can't understand another person and what they've been through unless you're in a relationship with them, and they have to be in charge of that process. We can't be there as saviors showing up to say, here I am to save the day. We have to recognize the strength of those people, the resilience of those people who have experienced these hardships, and the fact that there are studies that show that they are more generous than middle-class folks who've got life going on pretty well. And so they've got something to teach us too, in meeting them where they are. And so, so I think we've got to reimagine the way that we encounter people, and be open, and not in such these cookie cutter programs and other ways, but be open to meeting people and doing exactly what they ask us to do.
Okay, specifically as an individual, what should we be doing about these disparity issues?
Yeah, Susan, I wanted to just add to that quickly. Dan, I don't know if you wanted Dan to do it, but I just wanted to just have just chime in. So, I mean, I know that within our strategy plan, what we try to do is analysis on different regions. So the idea is to engage the leadership to be able to fill in the gaps as to where, what areas, what certain parts of the community are not getting serviced, or there's just basically a gap in between, and we're just not connecting with them. So my idea is, at least in the commission standpoint, what we try to do is engage with the leadership to identify those gaps so that we can be able to resource in whichever way possible. And even if filtering out information, if it's obviously, if it's available to them as it relates to funding, et cetera, we want to be as resourceful as possible. But as a community standpoint, what I've seen in other different cities do is actually have stakeholder meetings amongst all nonprofits and medical professionals and leaders, elected officials within their communities to also to identify where those gaps are as well. So I just want to just add that piece, because I thought it really speaks to what Dan was also mentioning in terms of the resources.
Those are really, really good suggestions. Thank you, Liz. Dr. Hamblin, you've really outlined a lot of the interesting points that we need to think about and then work on. One other thing I just wanted to add quickly, which I should have brought up earlier, is the disparity in mental health issues during COVID reported by people of color. I think it was something like about half of people of color reported mental health issues and stressors compared to 21% of whites during COVID. And I don't think that's because of just COVID. I think what we're hearing is it's all the stressors in life. It's poverty, it's unemployment, it's the pressure to go back to work when you're an essential worker and you're not making much money and you have a family at home. It's the schools being shut down. All those stressors can stress certain demographics a lot more than people who have the systems designed for their preferences. So Dr. Hamblin, would you give us some specific suggestions?
Absolutely. I mean, the stressors that you mentioned, yes, they're there, but they're there every day. And most or many Black people and other people of color never left work. We've been there the whole time. So, we've been there with the stress of school, but the police interaction and the difficulty in surviving a law enforcement interaction, seeing over and over uh, death by the hands of police while Black, while just living your normal life, that has been a particular additional stress. And this awakening that was mentioned, is great. But if that awakening comes with, let me check on you, how are you doing? I personally, and many other people of color working in white spaces, let me pull this scab off and share my pain with you. Are you going to be a part of putting me back together? Or are we going to continue to have meetings and talk about things? And then when it comes time to write the check, to make the policy, to really dismantle this system, there isn't enough action. And so I think that the action items for moving forward with health, which is absolutely related to economics, if you don't know what to do, don't have a meeting. Let's not talk. Write a check. Make that contribution to the NAACP, to Union Community Care, to your favorite nonprofit or organization that is led by or serving people of color. Learn something. Expand your mind. Put yourself in someone else's shoes by doing your own work, not by asking your Black friend or colleague to talk to you about their experience. We're not here to give people crib notes. There's plenty and plenty of resources. And then if you're, in a decision-making place, make decisions that advantage people of color, period. It is not unfair or to make a policy that advantages people of color. We are trying to achieve equity. So for fixing inequality and the effects of systemic racism, bold actions are needed. It is imperative. This Lancaster community is a very special community, and we can do so much more than what we're doing if we put our heads together and put action behind the promises and the stance that are made. Action can include support, but it includes finances and resources because people know what to do.
Thank you very much. Those are important words, and specifically that policing is a public health issue that we are all going to have to face. I just want to ask Kevin if you have anything to add to this important discussion.
Well, you asked everybody specific. So I'm going to end this with something I forgot to mention at the beginning, which we know the CDC changed their masking guidelines yesterday. And I'm going to tell you this, I am fully vaccinated. I have been for a long time, and I will continue to wear my mask in public spaces. Just because you don't have to do something doesn't mean you shouldn't do something. And one act of, we'll even call it activism or protest that you can do, is to say that we're not out of this pandemic. And even if you're fully vaccinated, you're going to demonstrate the severity and the sincere necessity that we continue to make tangible action. So I'm going to continue to wear my mask in public spaces, even if I don't have to. Now, going over to someone's house and having dinner and everybody's vaccinated, that's a different thing. But as an act of defiance that we are not beyond everything, I'm going to wear my mask in public spaces. Then the other thing that I want to say is I want to thank Dr. Hamlin for her comments about active ways that you can get involved. We here at United Way are run by an African-American and man. So consider us as at least a location to consider financially supporting, but also certainly those on the ground organizations. I want to thank each and every one of the panelists here. I want to thank all of you for taking time to attend. There were some great comments and conversations that happened there. I will lastly say United Way has been part of a piece of legislation with Senator Bob Casey. I spoke at a roundtable on Monday called the HELP Act and also SIA. This works at removing non-emergency phone calls from 911 and putting it into the 211 network, which lowers the interactions between police and communities of color and those suffering mental health issues in a way that will guaranteed lead to less negative interactions, because if you remove the possibility, you remove the end result. It's not an anti-police thing. It's actually supported by the Fraternal Order of the Police, because they recognize they are not social workers and that we need to get people to the places where they are best going to be served holistically. So if you're looking for something to write a letter for, please thank Bob Casey and Senator Moran from another state who's a Republican co-sponsor, and encourage all of your legislators to support legislation that actually looks towards solutions instead of hand-wringing. Thank you all for your time. Thank you, Susan, for moderating. Thank you, panelists. Thank you, Brenda, for your presentation. Appreciate you all. And with that, we'll look forward to our next conversation in about a month's time on public health issues. Thank you for all of you supporting United Way's endeavor into these conversations. I was told when I started it that it was not wise to do so, that this is a political kettle, and I said, don't care. We're going to do what's right for the community. And so thank you for being a part of that. Take care, everybody.